I'm Dr. Terry Kaplan, a urogynecologist at Columbia University Irving Medical Center, and this is our team. Pelvic floor disorders are medical conditions of the bladder and bowel caused by weakened pelvic muscles and support. The three most common pelvic floor disorders are prolapse, urinary incontinence, and fecal incontinence. This video will review each of these along with vaginal atrophy. While these topics are rarely discussed due to their sensitive nature, pelvic floor disorders are very common, affecting 1 in 3 women. I will be reviewing prolapse. Prolapse occurs because a woman's pelvic floor muscles and ligaments are weakened, causing the walls to stretch. The most common symptoms are a bulge protruding through the vagina, pelvic pressure, and irritation of the bulging skin. The bulge may also make it difficult to empty urine or stool. This is a depiction of a normal pelvis. The woman is looking here to the left. This is the bladder, uterus, vagina, and rectum. Prolapse can occur in 3 different areas: along the anterior vaginal wall between the bladder and the vagina, at the top of the vagina here at the uterus, and along the posterior vaginal wall between the vagina and the rectum. Often, prolapse affects all 3 areas. Prolapse of the anterior vaginal wall is also known as a cystocele. This is the wall between the bladder and the vagina, and as you can see, the anterior vaginal wall is protruding beyond the vaginal opening here. This can make it difficult to empty urine. Prolapse at the top of the vagina can occur, known as uterine prolapse. This illustration depicts the uterus prolapsing beyond the vaginal opening. You can also appreciate that both the anterior vaginal wall and posterior vaginal wall are affected. Prolapse of the posterior vaginal wall is also known as a rectocele. This is the wall between the rectum and the vagina, and you can appreciate here the posterior vaginal wall is protruding beyond the opening of the vagina. This may make it difficult to empty stool during a bowel movement. There are several treatments for prolapse. These include conservative treatments patients can do at home on their own, physical therapy, and Kegels, which patients can perform on their own or in consultation with a physician or trained physical therapist, and a pessary, such as the one seen here at the top right corner. This is an intravaginal device that's placed inside the vagina to push the prolapse up. Also, there are a variety of minimally invasive surgical treatments via vaginal surgery, laparoscopy, or robotics. If you believe you have prolapse, avoiding anything that places pressure or strain on the pelvic floor will help. This includes eliminating chronic coughing, chronic constipation, and repetitive heavy lifting. Modest amount of weight loss can also improve symptoms. These may improve symptoms and prevent progression.
Thank you, Dr. Terry Kaplan. Hi, I'm Dr. Eli Shaw, another urogynecologist here at Columbia, and today I'll be discussing common urinary issues that many women deal with. First, let's talk about urinary incontinence. The ability to be able to control when and where we'd like to urinate is something we'd all love to have. We call that continence. When we lose that ability and we leak urine without control, we consider that incontinence. There are 3 main types of urinary incontinence: stress, urge, and mixed. First, let's talk about stress urinary incontinence. This is the most common type and occurs whenever there's an increase in abdominal pressure. So women leak when they laugh, cough, sneeze, or exercise. This often occurs after childbirth as well as after menopause. Nearly 15 million adult U.S. women face stress urinary incontinence. Risk factors can include age, childbirth, injury to the pelvic floor, obesity, chronic cough, constipation, and connective tissue disorders. Not many women realize that there are options for treatment for this type of incontinence. The next type of incontinence is urge urinary incontinence. This is the second most common type. Now, this occurs when a woman has a strong urge to go to the bathroom, but is unable to make it in time. An estimated 12 million adult U.S. women face this, and this is often seen in more of a postmenopausal setting, but can also be seen in younger women too. Risk factors here include age, smoking, obesity, diabetes, neurologic disease and injury, as well as many bladder irritants. The third type of urinary incontinence is actually a mixed picture. It's a combination of both stress and urge. Many women have a combined picture where they experience both types of incontinence. And For these women, we often try to find out which type of incontinence bothers them more and start with our treatment strategies there. Other than urinary incontinence, other things can also affect our bladder health. The most common issue being an overactive bladder. This is a condition where women have the sensation or sudden need to urinate. Other symptoms that women often have is urinary frequency, when they're often going to the bathroom. Nocturia, where they are urinating more than once a given night, as well as having a sensation of incomplete bladder emptying, or causing them to go to the bathroom over and over again. This could also lead to urinary incontinence as well. Both urinary incontinence and overactive bladder treatments start at home with healthy bladder habits. Once we maximize how our bladder works and what we put into our body, we can then formulate a plan of what further treatments you may or may not need. One of the most important parts of bladder health includes what we put into our bladder. Bladder irritants are compounds that can cause our bladder to overreact, which often leads us to feel the sensation of both urgency and frequency, and at times incontinence. Common bladder irritants are caffeine, carbonated beverages, artificial sweeteners, and alcohol. Limiting these can help decrease our sensation of frequency and urgency. Other things that we can do at home is decreasing our fluid intake to 48 to 64 ounces a day, and trying to do bladder training, where we train our bladder to void every 3 to 4 hours. Another mainstay of treatment is physical therapy. Physical therapy can be done at home as well as at the office with a physical therapist. Some physical therapists also allow telehealth visits too. Healthy bladder habits are just a start to gaining control of our bladder health. The urogynecologist here at Columbia can help you find a treatment strategy that's specific to your condition, including both conservative treatments that we just spoke about, as well as non-conservative treatments to maximize your bladder health. This can include physical therapy, voiding techniques, vaginal devices, medications, as well as surgery based on what your goals and condition are. Thank you.
Hi, I'm Dr. Svetlana Loza with Columbia University Irving Medical Center Urogynecology, and today I'm going to be talking about fecal incontinence. Fecal incontinence is also known as accidental bowel leakage. It is involuntary loss of solid or liquid stool, and up to 25% of women experience this condition. Incidence of condition increases with increasing age, and it is estimated that 88% of women who develop fecal incontinence develop the condition after age 40. 2/3 of the women who experience fecal incontinence do not seek any care. There are multiple risk factors for fecal incontinence. Some of the common patient characteristics are increasing age, female gender, smoking, and obesity. Gastrointestinal factors are large risk factors for fecal incontinence. Patients who experience loose or watery stools, frequent bowel movements, rectal urgency, or inflammatory bowel disease have a higher likelihood of having fecal incontinence. Patients' obstetrical history is extremely important to review. Patients' parity, mode of delivery, history of episiotomies, as well as history of 3rd or 4th degree perineal laceration can contribute to fecal incontinence. Patients' medical comorbidities such as dementia, Parkinson's disease, multiple sclerosis, and diabetes can play important risk factors for development of fecal incontinence. When we talk about medications that can predispose patients for fecal incontinence, common medications are medications used for management of diabetes mellitus, such as metformin, calcium channel blockers used for management of hypertension, as well as benzodiazepines and antipsychotic. Patients' prior surgical history can also predispose them for fecal incontinence. Some of the surgeries are hysterectomy, gallbladder surgery, or anal surgery. Once patients present with fecal incontinence, it is important to perform careful medical and surgical history. During inpatient examination, we perform detailed pelvic and rectal and anal exam, paying careful attention to muscles, sensation, and nerve function in a perineal area. There are multiple treatment options for fecal incontinence. Today, we're going to be centering mostly on conservative treatment options. However, there are multiple surgical options as well. First, a conservative treatment option that we're going to be talking about is diet and bowel habits. We carefully review patients' food and beverage diary, as well as caffeine and fiber intake. When we discuss fecal incontinence, it's important to discuss bowel movements, their stool consistency and frequency with patients, as well as positioning of the patient during the bowel movement. Some of the treatment options for fecal incontinence center on skincare. So we encourage use of soft toilet paper, washing around the anus when possible, avoiding products with perfumes and therefore avoiding the skin irritation, as well as encouraging use of cotton underwear. There are multiple medication regimens available for treatment of fecal incontinence. Bulking agents are one of those medications. Most common bulking medications used are psyllium, which is better known as metamucil, and methylcellulose, better known as Citracil. Both of these agents are available over the counter. Second group of medications used for treatment of fecal incontinence is antidiarrheal medications such as Lomotil and Repelamide. And then there are other specific prescription medications that can be used for treatment of fecal incontinence. Last but not least, treatment option for fecal incontinence is pelvic floor exercises. These can be performed in a form of pelvic floor muscle straightening exercises that can be done by patients themselves or with a pelvic floor physical therapist. Thank you so much for your attention.
Thank you, Dr. Lozo. I'm Neera Somasundaram, nurse practitioner at Columbia University Medical Center in urogynecology. Today I'll be talking about some of the physical changes that occur in the vaginal area during menopause. Vaginal atrophy, also known as atrophic vaginitis, is a condition caused by a decrease in estrogen levels in the body. This decrease in estrogen leads to bothersome vaginal symptoms. Studies show that about 50% of postmenopausal women experience vaginal atrophy symptoms, but only about 7% seek treatment. Some of the symptoms of vaginal atrophy are dryness, burning, pain, a lack of lubrication, painful sex, and urinary symptoms such as urgency, burning, and recurrent urinary tract infections. When we look at the vagina, we can see changes in both the internal and external anatomy, changes such as thinning of the vaginal tissue and a decreased elasticity in the skin. We can also see cracks on the skin surface and a decreased lubrication. There is no test for vaginal atrophy, but a diagnosis is made in the office by examining the vagina, listening to patients describe their symptoms, and if there are no other obvious causes for these findings, such as an infection. Some over-the-counter treatments that can help are vaginal lubricants and moisturizers. Lubricants are good for intermittent symptoms. They are short-acting and they're used just prior to intercourse. Some examples are KY jelly, Astroglide, and Slippery Stuff. For chronic dryness, there are moisturizers. They need to be used regularly to maintain moisture and hydration. They provide longer-term relief. Some examples are Replens, and KY brand makes a moisturizer, as well as a product called Liquid Beads that are inserted into the vagina. Lastly, we use vaginal estrogen to treat vaginal atrophy. It is applied directly into the vagina and supplied as a vaginal tablet, a cream, or a vaginal ring. Only a very small amount of estrogen is absorbed into the body. Estrogen helps thicken the vaginal tissue, increase blood flow to the vagina, improves lubrication, and improves urinary symptoms, as well as decreases pain. Most women feel relief from their symptoms after 3 weeks of use. Some women need about 4 to 6 weeks to notice improvement. It requires a prescription for use. If you have any questions or would like to schedule a visit, please contact us. Thank you.